So today we'll be discussing a very important topic called hyperthyroidism. So thyrotoxicosis is a clinical, physiological, and biochemical findings that result when the tissues are exposed to excess thyroid hormone level. And the specific diagnosis is very important as it determines the therapy and the prognosis of the patient. Hyperthyroidism is a condition when there is a hyperfunctioning of the thyroid leading to thyrotoxicosis. So there is a little difference between the thyrotoxicosis and hyperthyroidism. So in thyrotoxicosis, there is actually increased level of thyroid hormone levels, which could be because of the hyperfunctioning of the thyroid gland, or it could be related to some other causes. While in case of hyperthyroidism, it is basically the hyperfunctioning of the thyroid glands leading to increased level of thyroid hormones, which then in turn leads to thyrotoxicosis. So the genetics of autoimmune thyroid disease. Autoimmune thyroid disease includes the Graves' disease, Hashimoto thyroiditis, atrophic autoimmune hypothyroidism, postpartum thyroiditis, and Graves' ophthalmopathy. And there appears to be a common genetic predisposition in all of these disorders. There is a increased incidence of these hormones in particular sex, mostly related to the sex steroids. And there is increased incidence of these autoimmune thyroid disease among the twins, and especially there is increased incidence of Graves' disease and autoimmune hypothyroidism among the monozygotic twins. Genetic factors play an important role in 70% of the Graves' disease. And in the sibling studies, sisters and children of the male with Graves' disease have increased 5 to 8% risk of developing Graves' disease or autoimmune hypothyroidism. So on the background of the genetic predisposition, environmental factors are thought to contribute to the development of the disease. The CTLA4, it is associated with Graves' disease in Caucasian populations, and the CT60 allele, it is highly associated with Graves' disease. HLA-DR3, it is also associated with Graves' disease, especially in the whites. HLA-DQA10501 it is associated with Graves' disease, especially among the male members. So the manifestation of hyperthyroidism in all forms. The symptoms include hyperactivity, irritability, altered mood, and insomnia. There would be increased heat intolerance and increased sweating, palpitations, fatigue and weakness, dyspnea, weight loss with increased appetite. However, weight gain is associated in around 10% of the patients. There would be pruritus and there would be hyperdefecation, leading to increased stool frequency, thirst, and polyuria. So overall, there is increased metabolism in the body, which leads to increased consumption of energy, leading to thirst and polyuria. There is oligomenorrhea and amenorrhea and loss of the libido and erectile dysfunction among the male members. So among the females, there would be oligomenorrhea or amenorrhea. And in case of male, there would be loss of libido and erectile dysfunction. And 50% of the male may have sexual dysfunction. On the other hand, if we see the signs, there would be sinus tachycardia and atrial fibrillation. So whenever there is atrial fibrillation, everyone, all the patients should be tested for the hyperthyroidism. Fine tremors, hyperkinesia, and hyperreflexia can also be expected in these patients. The skin won't be warm and moist, and there would be pulmonary edema and onycholysis. Since there is hyperdynamic states, again, we can expect the pulmonary edema. There would be hair loss since there is increased metabolism, increased cell turnover, which leads to hair loss. Muscle weakness and wasting. As we know, there is increased catabolism of the proteins, which leads to muscle weakness and wasting in these patients. Congestive high output cardiac failure, as this is a hyperdynamic state, these patients can have congestive heart failure, chorea, and periodic paralysis, especially in the Asian males. And sometimes these patients can also present with psychosis. So the investigation of thyrotoxicosis. Thyroid function test should be checked. So this is the baseline investigations. We can expect increased level of FT4 and suppressed TSH. However, FT4 can be increased in T3 toxicosis. The TRAP antibodies should be checked, and using the second and third generation TRAP assays, as these assays increase the sensitivity and specificity of diagnosis of Graves' disease by greater than 95%. TRAP levels decline. So TRAP levels have prognostic and diagnostic importance. So if the patient has a very high level of TRAP antibodies, then it is associated with increased severity of the disease and increased incidence of the occurrence of Graves' ophthalmopathy. And the TRAP levels decline with the passage of time, especially when the patient uses antithyroid therapy and after thyroidectomy. So with antithyroid drugs and thyroidectomy, the TRAP levels would decline with the passage of time. However, on the other hand, the levels would increase for a year following the radioactive iodine therapy, and then it would gradually increase, gradually fall slowly and gradually. If the patient who is pregnant and has a TRAP antibody level which is greater than 5 international unit per liter with a current or previously treated Graves' disease, we can expect the high risk of fetal and neonatal thyrotoxicosis, and hence these patients should be closely monitored during the pregnancies. So any patient with a history of Graves' disease in the current pregnancy or in the previous pregnancy, we should always check the TRAP antibody level, TRAP antibodies level. And if it is greater than 5 international unit per liter, then we should consider monitoring for the neonatal thyrotoxicosis. TRAP levels parallel the course of the Graves' ophthalmopathy. So the higher the level of the TRAP antibodies, there's an increased risk or increased chance of development of Graves' ophthalmopathy. And in case of if the patient has like the patient has thyrotoxicosis and you are planning for the radioactive iodine therapy, then with a patient who has a higher level of TRAP antibody level, we should give them steroid prophylaxis before giving the radioactive iodine, as it prevents the progression of the orbitopathy. Radionucleotide thyroid scan, if the thyroid scan can also be considered if the diagnosis is uncertain, or ultrasonography can also be considered, as in the ultrasonography, there would be increased vascularity in case of Graves' disease, while it can have a decreased vascularity in other situations. But now it is seldomly required, as there is, TRAP levels and thyroid scans are commonly used. So the manifestation of Graves' disease, there would be diffuse goiter with bruit, there would be orbitopathy, feeling of grittiness and discomfort in the eye, retrobulbar pressure or pain, eyelid lag or retraction, periorbital edema, chemosis, a combination of the scleral injection, exophthalmos, extraocular muscle dysfunction, exposure keratitis, optic neuropathy, localized dermopathy, which is called a pretibial myxedema, or the because of the lymphoid hyperplasia. Thyroid acropathy can also be present in these patients. So the tests which help to differentiate different causes of thyrotoxicosis. So thyroid iodine uptake scan. So thyroid iodine uptake scan, there would be increased uptake in case of Graves' disease, toxic nodular goiter, TSH secreting pituitary adenoma, hyperemesis gravidarum, and trophoblastic tumor. On the other hand, if the patient have thyroiditis of any cause, like dequervin thyroiditis, drugs like amiodarone-related thyroiditis, stroma ovari, or thyrotoxicosis factitia, in these situations, the thyroid iodine uptake would be low. TPO antibodies can be present in Graves' disease, and TRAP antibodies is positive in Graves' disease only. So it's quite specific for the Graves' disease. Thyroglobulin levels would be increased in all the situations except the thyrotoxicosis factitia. So if there is a confusion between different causes and you are suspecting thyrotoxicosis factitia, then among the other studies, thyroglobulin would be a better discriminating test. So the condition associated with Graves' disease are type 1 diabetes, Addison's disease, vitiligo, pernicious anemia, aplastic alopecia areata, myasthenia gravis, celiac disease, other autoimmune disorders associated with HLA-TR3 haplotype. So what are the aims and principles of medical treatment of the hyperthyroidism or Graves' disease? So if the patient has Graves' disease, our aim should be to induce the remission. And we should monitor these patients for the relapse once the treatment is stopped. Initially, we follow these patients with 6 to 8 weekly for the first 6 months. And once the patient become euthyroid, then we follow them 6 monthly for 2 years, and then annually thereafter, as soon as if the symptoms return. For relapse, consider definitive therapy like radioactive iodine or surgery. A second cause of antithyroid drug rarely results in remission. So if a patient is started on antithyroid medications and there is no remission at the end of the 18 months, then there's a very less chance that the second course of antithyroid drug would lead to remission. So the choice of drugs like thionamides, carbimazole is a drug of choice. Carbimazole, it goes to the liver, and that cleavage of the carboxyl side chain occurs, which then leads to conversion of carbimazole to methimazole. The side effects are less with carbimazole compared with propyltyrosol. The side effects occur in 14% of the carbimazole treated patients, while side effects can occur up to 52% of the patients treated with propyltyrosol. PTU is propyltyrosol is never the first line agent, especially in children or adults. PTU is usually given in the pregnant women and in life-threatening thyrotoxicosis. So PTU can also be given when neither surgery nor radioactive iodine is a treatment option in a patient who has developed a side effects, not agranulocytosis, to carbimazole, and antithyroid drug is needed. So in the first trimester, carbimazole can lead to aplasia cutis. So PTU is preferred in the first trimester. So the action of these medicines include blockade of the action of the TPO, thyroid peroxidase, which leads to decreased production of thyroid hormone. These medicines are actively accumulated in the thyrotoxic tissue, thus leading to increased inhibition of the thyroid hormone synthesis. And PTU also inhibits deiodinase type 1 activity, and thus may have advantages when given at a higher doses in severe thyrotoxicosis. So in thyrotoxic storm, PTU is preferred as it inhibits the deiodinase type 1, which thus has an additive benefit. So the dose and effectiveness, carbimazole of 5 mg dose is equivalent to 50 mg of PTU. PTU inhibits T4 to T3 conversion, and T3 levels decline more rapidly with PTU. So 40% of the patients treated with antithyroid drugs remain euthyroid for 10 years after the discontinuation of the therapy. So roughly 50% of half of the patients treated with antithyroid drugs become euthyroid by 10 years of after 10 years of therapy. So if hyperthyroidism recurs after the treatment with antithyroid drug, then there's a very little chance that the second course of treatment would lead to permanent remission. So young patients, smokers, and those with a large goiter, ophthalmopathy, or high serum concentration of TRAP at the time of diagnosis are unlikely to have a permanent remission. So it is very important to consider about the treatment options when the patient comes to you for the first time. So these are the poor prognostic markers, poor prognostic indicators regarding the remission. Like if the patient is young, smoker, large goiter that is greater than 80 gram, ophthalmopathy, especially moderate or severe, high serum concentration of TRAP. If these parameters are present at the diagnosis, then there's a very little chance that the patient would have a permanent remission with antithyroid medications. Beta blockers, propranolol can be given at a dose of 20 to 80 mg 3 times a day. It is given for the symptoms, including the anxiety, tremor, and palpitations. These medicines are given for the first 4 to 8 weeks of treatment. And once the euthyroidism is achieved, then they are gradually withdrawn. So antithyroid drugs are generally well tolerated. The patient can have GI symptoms. There can be alteration of taste and smell. Agranulocytosis can occur in 0.1 to 0.5% of the patients. It is more with PTU compared with numercazole. There's cross reactivity between the PTU and numercazole. So because of the cross reactivity, one drug should never be substituted for the other one. Agranulocytosis generally occurs in the first 3 months, and in 97% of the patients, it usually occurs in less than 6 months. And the risk of agranulocytosis is higher with higher doses compared to lower doses. And in case of agranulocytosis, we should consider granulocyte colony stimulating factor, which can be helpful. So agranulocytosis occurs suddenly and it is usually fatal. It is therefore the routine full blood count is of little use. Fever, so the patient should be instructed that if there is evidence of fever and evidence of infection, especially in the oropharynx, then they should consult their doctor and should stop their medication right away and consult the doctor as soon as possible. It is more commonly seen in males, and it is fatal in the elderly patients. In 1 to 5% of the patients, there could be allergic type reaction such as rash, urticaria, and arthralgia, which could be mild and usually do not necessitate a drug withdrawal. One drug may be substituted for another in the expectation that the second agent may be taken without the side effects. So this substitution is basically in case of allergic type reaction, not agranulocytosis. So these medications can lead to cholestatic jaundice, and elevated serum aminotransferase have also been reported, and sometimes fulminant hepatic failure can also occur, especially with PTU. So PTU-related severe lung injury can occur in 0.1% in adults, and 10% will develop liver failure, leading to liver transplantation. So drug-induced liver failure, it is greater for the children than adults. So PTU is never a first choice in the kids. Carbimazole is associated with increased congenital malformation when it is used in the first trimester and especially at higher doses. The higher doses means that if it is used at greater than 15 mg or more. So the women of childbearing potential should use effective contraception during the treatment with carbimazole, and it should only be considered in pregnancy at the lowest effective dose without additional administration of the thyroid hormones. And we should closely monitor the maternal, fetal, and neonatal outcomes and health. Acute pancreatitis have been reported with carbimazole. So if there is any suspicion of acute pancreatitis in a patient who is using carbimazole, then this medicine should be stopped immediately and permanently. And carbimazole is contraindicated in those patients with a history of acute pancreatitis associated with previous treatment, as the re-exposure to this medication can lead to life-threatening acute pancreatitis with a decreased time to onset. These patients should be given written and verbal warnings about the potential side effects of these medications. ANCA-negative vasculitis is associated with PTU, leading to arthralgia, skin lesions, glomerulonephritis, fever, and alveolar hemorrhage. So the skin lesions can manifest in the form of ulcers, and biopsy is usually needed to confirm the diagnosis of vasculitis. PTU is stopped and steroid may be needed in these situations. So the treatment regimen, like most commonly used regimen, is dose titration regimen. In this regimen, euthyroid state is achieved initially with a higher doses, and the euthyroidism is then maintained with the lowest stable dose. Thyroid function are checked 4 to 8 weekly, and the dose is titrated to keep the FT4 level in the normal range and the TSH in the detectable range. High TSH, if there is high TSH with the use of these medications, then there is a need of dose titration. It is important to note that the TSH may remain suppressed for weeks or at times months. So it is the FT4 level. So for the diagnosis, we check both the FT4 and TSH, but for the monitoring with regards to the treatment efficacy, we usually follow these patients with FT4 level. So the TSH may remain suppressed after normalization of thyroid hormone levels, and the usual starting dose of carbimazole is 20 to 30 mg. So we roughly calculate the dose of the carbimazole depending on the FT4 level. So if this is 2 times higher than the normal, then the usual dose is between 20 to 30 mg. If it is greater than 3 times of the FT4 level, then usually the usual starting dose is 30 to 40 mg. And if it is greater than 4 times, then the usual starting is 40 to 50 mg per day. So higher doses, that is 40 to 60 mg, can be used in severe cases with very high levels of FT4 level. This regimen has a lower rate of side effects than the block and replace regimen. The treatment is usually continued for 12 to 18 months, and it is very optimal in producing remission rate in up to 40% of the patients at 5 years after the discontinuation of the therapy. Relapses are more likely to occur within the first year. Patients with large goiter, if there is associated orbitopathy, if the patient is currently smoking, if there is high FT4 level at diagnosis, and the presence of TRAP at the end of the treatment, male have a higher recurrence than female, and multinodal goiters and thyroid nodules and thyrotoxicosis will always relapse on cessation of the anti-thyroid medications, and definitive treatment with radioiodine or surgery is usually advised. So in multinodal goiter and thyroid nodules, it is these patients need treatment with radioactive iodine or surgery, as the chances of recurrence would be much higher on stopping the antithyroid medications. So the long-term medical therapy at a lower dose is also an option, particularly for the elderly patients. So the risk of relapse and trap. Relapses can occur in the first year with either treatment regimen. The higher the trap levels at diagnosis, the greater the chances of relapse in the subsequent years. So if the trap levels are greater than 12 international unit per liter at diagnosis, then there's a 60% chances of relapse at 2 years and 84% chances at 4 years. So elevated trap level favors definitive treatment in the form of radioactive iodine or thyroidectomy, depending on the presence or absence of moderate to severe graves of thermopathy. So as discussed, radioactive iodine can lead to worsening of the graves of thermopathy. So before considering radioactive iodine, we should first assess if the patient is associated graves of thermopathy or not. So if the graves of thermopathy is mild, when we can consider radioactive iodine. Was in case of severe or moderate to severe ophthalmopathy, radioactive iodine is generally avoided. So persistently high trap at 12 to 18 months can continue antithyroid treatment. Repeating the trap measurement after an additional 12 months or opt for the therapy with radioactive iodine or thyroidectomy. So if the patient relapses after completing a course of antithyroid drug, a definitive treatment is generally recommended. Sometimes the patient can also pursue a long-term low-dose antithyroid medication if they prefer so. So the radioactive iodine treatment, the indications include definitive treatment of multinodular goiter or adenoma and relapse Graves' disease. So these are the main indications for the radioactive iodine. The contraindications include young children, as there is an increased risk of thyroid carcinogenesis, potential and theoretical chances of thyroid carcinogenesis, pregnant and lactating women, avoid conception for at least 6 months following the radioactive iodine. Situations where it is unclear that the safety of other people cannot be guaranteed. Like if the patient is living in a family where separation, keeping the patient in isolation is not possible. So it is better to not to give these patients radioactive iodine. Graves of thermopathy may worsen post-radioactive iodine, especially in those patients who are actively smoking. So it is very important that the first-hand and the second-hand smoking should be avoided in these patients. Moderate to severe ophthalmopathy. Alternatively, if the patient is having mild ophthalmopathy or mild or moderate ophthalmopathy, then we can give steroid cover, that is prednisolone at 40 mg on the day of radioactive iodine. Then it is continued at the dose of 30 mg per day for the next 2 weeks, followed by 20 mg per day for the next 4 weeks, reducing to 0 over the next 3 weeks. So overall, this would be 6 to 7 weeks of treatment with a tapering dose of prednisolone. And lower dose steroids, starting with a PrEP of 20 mg, may also be effective in certain circumstances, depending on the severity of the Graves' ophthalmopathy. Once the euthyroidism is achieved, it should be maintained, as both the hyperthyroidism and hypothyroidism can lead to worsening of the Graves' ophthalmopathy. Trap levels parallel to the course of the orbitopathy. Elevated trap levels is indication for the steroid prophylaxis to prevent progression of the orbitopathy with radioactive iodine therapy. So the caveats associated with radioactive iodine is that the control of the hyperthyroidism can occur in weeks or in few months. So it is very important that these patients should be closely monitored. Greater than one treatment can be needed in some patients depending on the dose given. In 15% of the patients, second dose may be required, and in few patients may require a third dose. Second dose should be given at a gap of around at least 6 months after the first dose. And the compounds that contain iodine, like amiodarone, block the iodine uptake for months. So this should be considering while giving the radioactive iodine. So iodine uptake measurements may be helpful in this instance in determining the activity required and the timing of the radioactive iodine therapy. Women of childbearing age should avoid pregnancy for a minimum period of 6 months post radioactive iodine ablation. And male should avoid fathering a child for at least 4 months after the radiation therapy. The prevalence of hypothyroidism is over 80% at 25 years and continues to increase thereafter. So the side effects include anterior neck pain caused by the radiation-induced thyroiditis, transient rise in thyroid hormone levels, which may exacerbate the heart failure if present. This aspect needs consideration, especially in the elderly patients. Hypothyroidism after radioactive iodine. So post-radioactive iodine, antithyroid drugs are generally recommended, and they are withdrawn gradually with a thyroid function test, which are done 6 to 8 weekly. Early post-radioactive iodine hypothyroidism may be transient. TSH should be monitored initially and then annually to determine the late hypothyroidism. So in case of autonomous toxic nodule, the incidence of hypothyroidism is lower since the toxic nodule takes up iodine, radioiodine, while the surrounding tissue will recover normal function once the hyperthyroidism is controlled. Morbidity and mortality are not increased if the patient is euthyroid on levothyroxine therapy. So the cancer risk after the radioactive iodine therapy. There is no consistent evidence that radioiodine for hyperthyroidism increases the overall risk of malignancy or thyroid cancer. So the recommendation is to administer enough radioactive iodine to achieve correct hyperthyroidism with the acceptance of hypothyroidism. So instructions that should be given to the patients before treatment. Discontinue antithyroid drugs for 2 to 7 days before radioactive iodine administration, since their side effects last for 24 or more, although PTU has a prolonged radioprotective effect. That means if the PTU is given, if the patient is taking PTU in high doses, then there's a higher chances of radioactive iodine failure in these patients, as the PTU has a radioprotective effect. Antithyroid drugs may be recommended 3 to 7 days after radioactive iodine administration without significantly affecting the delivered radiation dose. Iodine 131 is administered orally as a capsule or the drink. There is no universal agreement regarding the optimal dose, and the patients are given different doses of radioactive iodine. So the outcomes of radioactive iodine treatment. 50 to 70% of the patient have restored normal thyroid function within the 6 to 8 weeks of receiving the radioactive iodine. There is shrinkage of the goiter that occurs, but it is slower. The cumulative incidence of hypothyroidism is more among the Graves' disease patients who are treated with radioactive iodine compared with those with toxic marginal goiter. Thank you.